Good afternoon, everyone. My name is Danielle Turnipseed, and I'm the Chief Public Policy Officer at the AAMC, that's the Association of American Medical Colleges. And on behalf of the AAMC, I want to thank each of you for joining us for this very important congressional briefing, which will serve as a GME 101 on the role of Medicare training in tomorrow's doctors. So you know, the AAMC is a nonprofit association, and we're dedicated to improving the health of people everywhere. That means in your members' districts. And we do that through medical education, patient care, medical research, and community collaborations. Our members include all U.S. medical, MD granting medical schools, and also 4 in Puerto Rico as well. Nearly 500 academic health systems and hospitals, and that includes the Department of Veterans Affairs medical centers, as well as more than 70 academic societies. And across these institutions, academic medicine touches the lives of millions of Americans, training the next generation of physicians while caring for patients and advancing discoveries that improve health. As many of you know, the nation is facing a growing physician shortage. In fact, the AAMC projects that by 2036, we could be as short as 86,000 doctors. That's how many we're projecting that we need. Patients across the country are already experiencing wait times that are too long and difficulty finding a physician. How many of you have had people talk about how hard it is to get a physician? See, here we go. Patients across the country are already experiencing wait times that are too long, and especially in rural and underserved areas. And that's because it takes almost a decade to train a doctor from undergraduate medical education, which is medical school, and then into their residency. So the good news is that the investments that we make today will determine whether every community can access the care it needs in the years ahead. So all physicians must complete graduate medical education or residency training before they can practice independently. It is a must. And that period of hands-on supervised training is where medical school graduates learn the skills, techniques, and judgment and apply that, and that will help guide them through their careers. Medicare has been the largest source of federal support for this training for more than half a century, and except for 2 increases in 2021 and 2023, that number has been essentially frozen since 1997. And teaching hospitals have stepped up to shoulder the cost of physician training, but that burden is increasingly unsustainable. We're going to talk about that. Today's briefing is designed to provide you with a clear foundation on how GME works. So we're all starting with a clean slate, and what the physician workforce shortage means for your constituents, and why Medicare's support for physician training is so critical to ensuring access to care. So let's get started. We're very fortunate to have an outstanding panel of experts with us. First, you'll hear from my colleague, Len Marquez. He is Senior Director of Government Relations at the AAMC. And let me do this. Yep. He leads our advocacy on GME and the physician workforce. Next, we are joined by one of our member institutions' notable physicians and leads in GME, Dr. Katie Henderson. She is Vice President and Chief Medical Officer of Barnes Jewish Hospital in St. Louis, Missouri. Anybody from Missouri? Okay. I'm going to be doing shout outs for the locations, so listen out for your area. And she also continues to practice as an attending physician in the primary care medicine clinic, so she's doing a lot. And finally, we are honored to welcome Dr. Chandra R.A. He is a surgical oncologist and Senior Associate Dean for Graduate Medical Education at the University of Nebraska Medical Center. Anybody from Nebraska over here? Front and center. And also, was there another hand? Well, yeah. You're with the University of Nebraska. But I also want to note that Dr. R.A.'s son is in from the Boston area, from Northwestern, where he's an undergraduate. So we're pleased to have him too. Dr. R.A. brings a wealth of experience as both an educator and a physician with a career that spans training in multiple healthcare systems around the world and leadership in medical education here in the United States. So the full speaker bios are in your materials, and I'm going to ask Len to come forward, but I'm also going to mention one person that is not included, and that's Allie Perlioni, who is in the back. Allie, she's the one that you're probably getting your messages from, your emails from. She is leading not only this briefing, but so much of the work that we're doing. So if you happen to have to leave early, be sure you contact Allie. And with that, thank you all for being here. And Len, over to you.
Thank you, Danielle. Hi, everybody. Good to see you all. Thanks for that introduction. So we're going to talk about graduate medical education today, as Danielle pointed out. We're going to talk about Medicare's role in that. And we're going to learn about the important partnership between the federal government and the nation's academic health systems and teaching hospitals and training the next generation of providers. So I think the first question that we usually ask is, well, what's a teaching hospital? And perhaps you've learned from television or the movies what a teaching hospital might be. But I would just tell you that a teaching hospital is any place where once a physician graduates from their medical school program, they match into a residency program, they do their training, as Danielle mentioned, usually 3 to 7 years, before they then go into practice, independent practice. From a AAMC perspective, what exactly are we talking about? We're generally talking about academic health systems and academic medical centers. There's about 1,100 teaching hospitals total across the country, but there's only a couple hundred large academic medical centers. And so what exactly do we mean by an academic medical center? That is where the patient care, the education and training of residents and students, the life-saving medical research, often funded by the NIH, and community engagement all come together to improve the health and care of communities and certainly your constituents. But who is the AAMC? So I mentioned those 1,100 hospitals. There's actually over 5,000 hospitals across the country. Our members make up about 5% of those hospitals. But as you can see, they provide a disproportionate amount of care and certainly specific specialized care, whether it's 100% of the comprehensive cancer centers, 75% of all the burn unit beds, vast majority of the top-level trauma centers, pediatric intensive care units. So as you can see, they're certainly providing that specialized care, but I think what's also very important to point out is that these are also your safety net institutions. We're providing nearly, or 27% of all the Medicaid hospitalizations, and again, remember this is 5% of hospitals providing this, and then over 30% of the charity care that happens in this country. So I think you can see their small size yet very unique role. So what exactly is GME? Well, we talked a little bit about the UME piece, or we refer to as UME, or undergraduate medical education. That's medical school. And then there's that 3 to 7 year period of residency, where a resident physician would do their initial training in a specialty. But very often, whether it's surgery or different types of mental health disciplines, really many, if not most, disciplines, there's an opportunity to follow up and do fellowship training. Now, one of the points we'll make later is the difference between funding for initial residency and then funding for fellowship programs. But we can talk about that in a little bit. And then, of course, once a resident and a physician finishes this, they're able to then go do their independent practice. And very often, I think in our situation, those physicians end up certainly staying in that community, and hopefully, for us, staying within our member institutions and becoming faculty. So who pays for physician training? Danielle mentioned Medicare, and absolutely Medicare is the largest public provider of support. But I would actually tell you that the largest provider of funding for graduate medical education is those teaching hospitals. And we're going to talk about the numbers and the actual cost in a little bit. But again, it's those teaching hospitals and those academic health systems who are supporting that, the Medicare program. But then there's also Medicaid graduate medical education. It's a little different. It is not mandatory. It's voluntary. States can make the decision as to whether or not they want to participate. Not all do. There's also VA, or the Veteran Affairs Department has graduate medical education. And then there's discretionary graduate medical education programs in HRSA, whether it's Children's Hospital, GME, the Teaching Health Center, GME. Those are just two of the other programs that are out there. Why does Medicare support graduate medical education, though? Well, if you go back to the 60s, when Congress created the Medicare program, basically they thought, well, if we're going to guarantee access or we're going to guarantee coverage, we ought to make sure that we are guaranteeing or doing our part to guarantee that there are actually physicians there to care for these seniors. And so they've really established this public-private partnership to help do all the resident training. So I think the takeaway from this slide is graduate or GME is expensive. It's about $25 billion a year to train all the residents. Now, I've been on the Hill or around DC for a long time, and I think we've done a pretty good job of working with folks and explaining that no, Medicare doesn't cover all of that. And that's been a question we've gotten in the past, right? Like, oh, how much does it cost? Yeah, Medicare pays for all that. Medicare does not. Medicare provides about $5.88 billion a year for physician training. Don't get me wrong, that is a substantial amount of money. It's a very much appreciated amount of money, and it's an important amount of money. However, that means there's almost $19 billion a year that needs to come from other sources, whether that's clinical revenue from our academic medical centers and other teaching hospitals. Again, there's also the Medicaid program, as we talked about. There's also state funding that states provide resources. But again, that is a significant amount of money that Medicare is not covering. So let's talk about the two types of Medicare GME payments. The first is direct graduate medical education, or DGME. This is the actual cost of training residents. Resident stipends and benefits, faculty costs, overhead. Think about anything you need to do, accreditation costs, anything you need to do to be able to actually get your programs up and running and then maintain them. The other less sort of understood or less talked about, and we've got some additional information on this we're going to talk about today, is indirect medical education payments, or IME payments. I will point this out again, but I think it's important to say it twice. These are not education payments. They have an education label, but these payments are made to teaching hospitals because they care for sicker, more complex patients. That's the reason that those payments are made. And if you think about trauma centers, burn units, think back to that first slide. What were those unique community services that our members are providing? Things we don't ever actually want to have to use, but we have to have them available 24 hours a day. So I gave you the big number, the $25 billion. This is a little bit of a breakdown. On average, it costs about $188,000 a year to train each resident, of which Medicare, and for direct GME, provides about $60,000 a year. Again, a significant investment. I think it's also important to point out that the amount of Medicare GME that your institution gets is directly tied to actually caring for Medicare patients. They don't just give you the money. So those institutions, such as our members, which are, I think upwards of probably 25% of the Medicare patients in this country come to AMC member institutions, that number is tied directly to the amount of GME you receive. And as I promised, here we are back a little bit more on IME. Again, it's a patient care payment. And you don't have to take my word for it. We should go back to when they created the IME payment, and it was Congress when they created the IME payment. And basically, they did it for a couple of reasons. One, and I think this is the one you probably hear about most often, residents are inefficient and they order too many tests. Perhaps, I think we'll hear from our panel whether or not they believe that to be true. But we don't often hear about is the other part of that, which is the fact that our members are caring for sicker, more complex patients and providing those community services that you don't find in other institutions. So what is so important about Medicare GME? What's the challenge we have with Medicare GME? Well, Congress back in the mid-90s capped the amount of support that the Medicare program can provide. And why did they do this? Well, we were projecting a physician surplus at that time, and it was also a way to save money. And so back in the Balanced Budget Act of 97, essentially Congress said, how many residents are you training at the end of your 1996 Medicare cost report? There's your cap. This isn't a national cap, it's a hospital level cap. So depending on how many residents your hospital had reported, or that academic medical center or teaching hospital had reported, that's essentially where their cap was set. And there are two individual caps. There's both a DGME cap and an IME cap, and that's because you can't necessarily count all the time. It gets very complex. But you can't necessarily count all the time for both of those, towards both of those payments. This is the second thing I think you should take home with you and remember. If you look at that, there are about 120,000 resident FTEs being trained across the country. And the cap is about, let's be generous, 95,000. So that means there are 25,000 residents being trained over and above those caps at, on average, $188,000 a year. So when we say academic health systems, teaching hospitals are the largest providers of GME, this is why they're the largest providers of GME. I would also point out that 80% of those positions are at AAMC member institutions. When you think of the large urban academic medical centers, those are AAMC members. Now, I think the other thing we should point out is we don't necessarily think about teaching hospitals, and that's not the focus anymore. We are thinking about and focusing on, again, I think you'll hear this from our panel, we're talking about academic health systems. These are large systems, often anchored by an academic medical center, but they've got rural hospitals, community hospitals, outpatient departments. They've got mobile clinics. They go out and reach communities and provide access to care for a variety of patients. And we'll talk about it again a little bit later, but absolutely that includes access to care for rural patients. So the question people usually ask is, well, what can you do about the cap? Are you able to raise your cap? No, you can't. The cap is in place. However, you can train as many residents as you can get accredited to train through the ACGME. That's the accrediting body for these residencies. But Medicare will only support up to that cap. Now, I want to thank those of you who were around in 2020 and 2022 and your bosses who voted for the CAA 21 and 23. That was the first increase in Medicare-supported GME positions since the cap went into place. 1,000 back in CAA 21 and 200 in CAA 23. There are also other programs. There's a rural track program. Essentially, that's where an urban hospital will, for lack of a better word, lend or loan or send residents, rotate them to rural hospitals. And both of those institutions then are able to raise and increase their cap to account for that. There are also GME affiliation agreements that allow hospitals to partner and send residents from one location to another. Teaching hospitals can close. There have been horror stories in recent years about teaching hospitals closing. But what happened pre-ACA when a teaching hospital closed was that those slots just disappeared into the ether, as we used to say. That is no longer the case. As part of the Affordable Care Act, those positions are now redistributed by CMS with preference given to those institutions who first take those displaced residents, but then also the idea is trying to keep them in that area, in that vicinity. And then the other piece I would just point out is for rural hospitals. Rural hospital caps back in 97 were set at 130%. And so they had a little bit of additional leeway built in there. And then rural hospitals rural teaching hospitals can actually grow programs and grow their cap. Can't take it from an existing program, but if you are in a rural teaching hospital and you decide you want to start a new program, you can have a 5-year window to grow your cap. And so some of them certainly do that. So very brief legislative history, 3 slides, because again, there wasn't very much. We had the Balanced Budget Act in 97 that set the cap. We had the CAA 21 that had the 1,000 slots, and CAA 23, which included 200 more. And I would just point out that in CAA 23, 100 of those positions were dedicated towards mental health and psychiatry and subspecialties. But as Danielle mentioned, the reason this is also important and the reason our members do what they do is because of we want to ensure access to care. But how can we ensure access to care if we are looking at a shortage of up to 86,000 physicians by 2036? Now, the biggest driver in all of this is something that we really can't do anything about, and that is the fact that the baby boomers are getting older, they're becoming Medicare eligible, and as people get older, they absolutely need more primary care, but what they end up needing is actually more specialty care. And so that is really the biggest driver in the shortage. Also, the country continues to grow. We continue to add more people. That increases the need for more physicians. But also, I think we also keep in mind, I'm sure you're hearing a lot about burnout issues in the healthcare workforce. That is certainly impacting our physician providers as well. I think the other piece of this I would just mention is that our physician population mirrors the rest of society. And our physicians are aging and getting older as well, and many of them are coming close to and entering potentially retirement age. Certainly no one on our panel, but that is happening. The other point I just wanted to make is about the academic health systems and their impact in rural communities. This is a map from the University of Colorado Health System. And of course, yes, you've got a large academic medical center. And we've had colleagues who used to say, well, the helicopter has to have somewhere to land. The helicopter that goes and picks up the emergency patient in one of these neighboring states has to go somewhere. And that still remains true. That's absolutely the case. However, we're now thinking about things, as I said before, as health systems. So you've got other hospitals in that academic health system who have access to those experts, whether they're in rural hospitals or community hospitals, community health settings, faculty plans. All of these locations have access to those academic medical centers. And so our members really are, I think, playing an important role in not just training the physicians that go to work in those communities, but also providing care to people in those communities, as they should. So just a very quick recap. Our members, why do they do this? It's their mission. That's what they're there to do. And I'm probably preempting the first question we're going to get at the end, but people always say, well, why do they train all those residents over the cap? It costs a lot of money. It's their mission. That's what they do. They take care of people. They keep them healthy. They train the docs. They educate the docs. They do the research, and then they go out into the community and provide that care. There are 2 types of GME payments. Direct GME, that is the payment that is for the actual training, and then those IME payments, which are the patient care payments. Again, that's how we pay for and support those trauma centers, burn units. Medicare GME has been capped since '97. There have been a couple of increases back in CA 21, CA 23. Again, thank you. Can't say that enough. We've been thanking folks for the last 5 or 6 years. Thank you so much for your support for that. But at the end of the day, to address that shortage of up to 86,000 physicians, what we really need to do, and the ask comes later, but we need to increase Medicare support for GME. But with that, there's the 101. Why don't I hand things over to Dr. Anderson? Oh, and there are seats in the front if folks need them. A couple.
All right, good afternoon. So I'm Katie Henderson, and I was asked to come speak to you all today just to give you a little perspective from the lens of a large teaching organization and how we essentially contribute to the ecosystem. So to do that, just a little bit about Barnes Jewish Hospital. We are part of BJC Healthcare. So our health system spans 14 hospitals. Barnes Jewish Hospital is our adult academic teaching hospital. We are right across the street from St. Louis Children's Hospital, which is our pediatric academic hospital. And as you can see, we cover a large geography, which does include some regional hospitals as well, including a rural emergency hospital. So Barnes Jewish Hospital, I'm not going to belabor all these numbers, but you get the point that we are large. We see a lot of patients, a little over 80,000 emergency department visits each year, over 52,000 admissions in 2024, and you can see our surgery numbers. So it's a big, busy place. A little bit more in-depth, it's a very interesting training environment for our residents and fellows because there are two sides to the coin here. We are recognized for leading-edge therapies, treatments, procedures, so the latest, greatest, any proton beam, robot, et cetera, you're going to find it there. We are a National Cancer Institute designated cancer center. We're a level 1 trauma center. But on the flip side to the coin, we are also very much an inner city safety net hospital as well for the city of St. Louis. So about a quarter of our patients have at least one social determinant of health identified. So that'd be things like being unhoused or having food insecurity. And actually that's based on coded data, so it's probably really a higher percentage than 25%. Very diverse patient population too. We have over 139 languages and dialects spoken amongst our patient population. We are a rural referral center, so Len mentioned that a little bit. What that means is that for our rural hospital partners, if they have patients who require a level of complexity in treatments or procedures that they do not have at their rural center, we will take those patients in transfer to our center to help with that. And then also of interest, we are a training site for the U.S. Air Force. And the reason for that is because we are a level 1 trauma center, they like to rotate. They send some short-term rotators to us, but we actually have some of their personnel who are embedded and work right alongside of our doctors and nurses. I think some of them have been there at this point for up to 3 years. So they're very much incorporated with us, and they like us as a training site, again, for that level 1 trauma center designation that helps them keep their skill sets up between deployments. Len also mentioned the census is going up. So this is our average daily census between 2018 and 2025. I'm sure you can tell that little blip there is during COVID when we stopped doing some elective procedures for a bit. But it is not uncommon anymore for us to run a daily census of 1,140 to up to 1,170. And on the bottom graph, these patients are getting sicker. So this is what we call the case mix index, or CMI. It's essentially a marker of acuity and how sick your patients are. So not only are we seeing more patients year over year, but these patients are sicker and more complex as well. So a little bit about what graduate medical education looks like at Barnes-Jewish Hospital. So we are governed by a consortium arrangement. So Barnes-Jewish Hospital, St. Louis Children's Hospital, Washington University School of Medicine, and we just added Missouri Baptist Medical Center, which is one of our large community hospitals. Those 4 entities are the governing body for our graduate medical education programs. So these are the employers of our residents and fellows, but this is also their major teaching sites where they see most of their patients. They do rotate outside of these 4 locations to places like the VA or Shriners or other facilities, but they would spend the majority of their time at one of these areas. We have 111 accredited training programs. We have just shy of 1,500 residents and fellows in the consortium between those 4 organizations. The majority of them, about 1,100, are at Barnes-Jewish Hospital. And we are over the cap, so Len mentioned that. So the consortium as a whole is almost 300 FTEs over the cap, and Barnes-Jewish Hospital specifically is 173 FTEs over the cap. So why would we do that? Because, as was mentioned, we do not get reimbursement for the residents and fellows who are over the cap. There are a myriad of reasons to support the mission of our center. Len already mentioned the shortage of physicians nationwide. You've all, and your families have experienced that when you've tried to make appointments. That is the same in our region. We are short of physicians, so we want to train the next generation. And some of the residents and fellows will stay to practice in the area where they trained. Not all, of course, but some of them do, so it does help us locally. And then there's actually a book of literature that shows hospitals that have training programs perform better in safety and quality metrics. And why would that be? I really think it helps us up our game as an organization. So anytime you have learners, they're inquisitive. They're always asking why. Why did you do this and not that? Why do we have this policy? This doesn't make sense to me. They are also very much on the front lines, And so they're seeing safety and quality concerns, bringing those to us, and then helping us come up with plans to address those. So they're very good partners. And then finally, this comes up sporadically, but COVID would be a good example of this, where our residents and fellows do provide a pool of deployable healthcare resources in emergencies. So a lot of teaching hospitals did see an influx of very sick and complex COVID patients during the pandemic, and we were able to quickly scale up because we had this workforce to help us do that. Medical education has changed a lot over the years. So I actually did my residency at Barnes Jewish Hospital, and I'll age myself and tell you it was almost 3 decades ago now that I started there as an intern. And the patient population has changed, but also how we actually just on a day-to-day basis teach the residents and fellows has changed as well. So adult learners want to learn differently nowadays. So we've learned about learning. So we do more competency-based training where our residents and fellows have to meet clinical milestones, but they can progress to graduated levels of responsibility at whatever pace they meet those clinical milestones. And there's been much more of a focus in medicine in general on health system science, population health, care delivery models, and our trainees need to learn about that as well. So for example, if we're teaching medicine residents to care for diabetic patients, yes, of course they know what medicines are at their disposal for treatment options for their patients, but we also want them to take a look at the population of diabetic patients as a whole. And are there differences in outcomes? So for example, if they look at the data by zip code, we already mentioned social determinants of health. So if they find an underserved zip code where their metrics may not be performing as well, we want them to be able to dig into that. Anyone who has diabetes, one of the first things we talk to you about is eating healthy. If you live in a zip code that's a food desert, that's very challenging to do. So we need them to find these issues and understand them and help partner with us to treat them. There's also a lot more focus on team-based and interprofessional training. So there are many more advanced practice providers, nurse practitioners, physician assistants, certified nurse anesthetists who are part of our healthcare teams now. Our residents and fellows need to understand what those colleagues do and how to work alongside them. A number of our residents, when they graduate, may be in a collaborative practice agreement with a nurse practitioner. They need to know what that looks and feels like and how to do that. So that's now part of our education as well. And then finally, interaction with technology. So this isn't just, proton beams and robotics for surgery cases, that's part of it, but even things like telemedicine. So we talked, for example, about partnering with our rural health centers, teaching them how to do things like use telemedicine to work with providers at the rural health center to better delineate, does this patient really need to physically transfer to us for their hepatology care, or can we help you treat in place with some of our hepatology experts providing you advice so that that patient can remain closer to their family and friends. So a lot of change over time. And with that, I'm going to turn it over to my colleague, Dr. Are.
Well, thank you for that nice introduction and the invitation to come and participate here. So it's my pleasure, privilege, and honor to be here, and I bring you all greetings from Nebraska. So your perspective is based on your background. So I just want to give you a quick shot about my background. I've kind of lived, trained, and worked in multiple continents and multiple countries across the world. So I may not be an expert on anything, but my perspective is definitely very broad. But here in the US, I trained in this part of the country for a long time. I was at Hopkins, and then I went up to Memorial, and now I've been in Nebraska for about 18 years. So what do all these precious lives have in common? They all will need health care once or many times. That means they will all need a physician once or many times in their entire lives. So physicians play a key role in delivering healthcare in America. Now, they don't do it alone. They do it as a part of a team. As Dr. Henderson mentioned, I cannot remove someone's cancer in the pancreas all by myself. I need a team. So now forgive me for using Husker terminology, but anything from Nebraska has to have some hints of Huskers. So if you look at the football team, there are 11 players. Everyone is important. But there's one person that's an anchor to that team. That's a quarterback. You can't play a football game with 11 quarterbacks. In the same way, there is a team, but there has to be an anchor, and the physician tends to be an anchor to that team. So here we are as physicians taking care of patients. When I counsel young men and women that want to come into medicine, I tell them, unless you're willing to obligate your life to the higher moral purpose of this profession, there are better ways and easier ways to make money. So we serve a moral purpose by becoming physicians. We provide timely, safe, and affordable care, and we are always thinking about value for money. I can't tell you the number of times I've told a resident, will that scan that's about $2,000 be worth to order? We make sure there's access. We try to incorporate technology, as Dr. Henderson mentioned. We just can't keep up with it. And the other thing that we've noticed as well is, in my career span, the type of patients that I've been taking care of have become more and more complex. And through all of that, we have to navigate the market forces, the healthcare trends, private equity trends, and then not to forget, physician suicide is a big concern for us. So we have to make sure we're also ensuring the well-being of the healer, not just who we're healing, but the healer has to be well as well to heal others. So Len gave an amazing talk, and I just want to point out something here. This is the Geminic report that predicted that there would be a surplus of about 70,000 physicians, and what an accurate prediction that was. But in any case, they gave out certain recommendations. If you look at recommendation number 2, restrict entry of foreign medical graduates, if they actually did that, I wouldn't be standing here talking to you. Nor would I have served the nation with pride for the last 30 years. Nor would I be taking care of patients in deep pockets of Nebraska, where some days I drive 8 hours to go into the rural pockets of Nebraska to take care of elderly cancer patients so that they don't have to drive 8 hours to come to Omaha. So with that being said, this is Nebraska. And if you look at the population for the first time, it crossed 2 million. And for the Nebraskans that are here, you probably know this. It's the 15th largest state, and we have 3 big cities in Nebraska. The first is Omaha, the second is Lincoln, and the third one, I think he knows, that's why he's chuckling, it's our football stadium on game day. So essentially, those are the 3 big cities in Nebraska. The rest of Nebraska is rural, and it's beautiful. If you haven't been there, you should come, except if you get really sick. Now, if you have a common cold or something like that, you need your appendix removed, that's not a problem. But sometimes anything more complex than that, that's a problem. So if you look at this map, everything blue is parts of the state with a population less than 15,000. So that's about Nebraska. Now let me talk about GME. So there is a body called ACGME that oversees the training of all residents and fellows in this country. So just for rough stats, these are updated numbers from just a couple of months ago. There's about 14,000 training programs, about 146 specialties and subspecialties, and about 900 sponsoring institutions that any hospital or entity that trains a physician, resident, or fellow is called a sponsoring institution, roughly about 170,000 residents and fellows. What is more important is 1 in 7 physicians in this country is either a resident or a fellow. So if you go to get healthcare, there's a 15% chance that that physician is actually a resident or a fellow. So house officers, as we call them, are residents or fellows. They're the backbone of healthcare delivery in America. And they are the frontline workers, as Dr. Henderson mentioned. This came out so clear during COVID that I'm not sure our entity or hospital would have survived without house officers during COVID. They actually kept the place going. While many others may or may not have come to work, they came to work every day. And we created special policies for them so that we could keep them coming back to work. And they have a very low turnover. Of all the workforces, not just in healthcare, but in general, house officers' turnover is so low, and that's why they're a very fiscally prudent investment. Now, just because they're fiscally prudent investment doesn't mean that they're cheap labor. They're a highly intelligent cog in the wheel of our healthcare delivery system. So I was on call last weekend, and we had some sick patients that came in. The frontline defense is a house officer. They see the patient, and then they call me. So when they do that, they already have given me some background, so it helps me add my skill set to that. So they are a very intelligent member of the healthcare team. And there's occasional mentions that they run around amok, there's no supervision. If anything, the problem we have is it's gone the other way. Sometimes we supervise them so much that we often wonder, once we let them off, will they be able to function independently? So they work in a highly supervised environment. And as Dr. Henderson alluded to, that's one of the main reasons why many of us stay in academic medicine. The joy of working with these bright young men and women, they keep us on our toes, and we're training the next generation of physicians. And whichever part of the world you're in, they are the best and the brightest that we can offer to ensure our societal obligations to humanity. So I mentioned to you about ACGME. There's about 900 sponsoring institutions. Nebraska has about 4. And this, of the 900 sponsoring institutions in the country, about 30% of them have only one training program. And another 30% have about 5 training programs. So collectively, 60% of the 900 sponsoring institutions have less than 5 training programs. And then there are a couple of places like Barnes-Jewish and University of Nebraska Medical Center. We have about 80, 100, or 150 programs, and that's the bottom 2 that you see there. So in Nebraska, by numbers, we have about 746 house officers, and I usually say it's a point of pride that, along with institutions like Barnes-Jewish, we train more physicians than 94% of all the other training institutions in the country. So the reality in Nebraska, I'll just let you at least briefly read through some of those bullets. This is a report that was published by Merv Reep, I think so, in December 2023. So you can see there's a word shortage that pops up very frequently. So there are maternity deserts in Nebraska, there's surgical deserts in Nebraska, there's psychiatry deserts in Nebraska, and there's primary care deserts in Nebraska. I could just go through the list and say there's ambulance deserts in Nebraska, there's hospital deserts in Nebraska. So the reality, while this may be applicable to Nebraska because I'm speaking on behalf of Nebraska, it's not isolated to Nebraska. It happens in many states, and in fact, when I was at Hopkins, not too far from Hopkins, in the outskirts of Baltimore, there were some healthcare deserts. So it just doesn't happen in rural America. It happens in the vicinity of urban parts of the country as well. There are not enough physicians, and the few that we have, they're difficult to recruit. And we just went out on a rural outreach. Even if they manage to recruit them, it's hard to keep them because the environment is usually not conducive. You can't be the solitary physician in a place. You need more than one physician to succeed there. So we do outreach. In the last 6 months, myself along with our interim chancellor, Dr. Dilly Davies, and Kyle Meyer, and Dr. Dean Brittigan, we went out to all these counties, and we visited about, I think, 12 hospitals. We met with the CEOs, CFOs, recruitment officers, the whole senior leadership. And what did we hear? We want physicians for providing healthcare to patients. We want to keep the town healthy. We want to keep the economy afloat. You've heard of college towns. There are hospital towns as well. Hospitals tend to be the economic engines or whatever size town they are in, and keep the societal fabric intact. You have a healthy population, not just the economy, but you have a healthy workforce. But the more important thing they say is, it's the way of life here. Unless someone is extremely sick, we want to get our care here. We want to stay here. So I see it as a moral imperative that we need to train more physicians to safeguard the health of all of us. Health security is security of the nation. Now, there's a conundrum when you think about healthcare investment in GME. This is where I'm going to put my MBA hat on. If you look at the investments, they're all in short term. You need to invest now. But the returns are all in long term. So they go beyond the typical 3-year business cycle or 4-year political cycle. But investments tend to be short term and returns tend to be long term and sustainable. The other one is the investments are tangible. You need to put greenbacks in it. But the returns sometimes are intangible. How do you put a price on lifespan? How do you put a price on prolonging lifespan that adds to the security of the nation? So I always say you can't save time by stopping the watch. If you want to save time today and cut GME funds, you're only going to incur more costs in the future when you're treating more complex patients. So that's kind of penny-wise, pound-foolish. Then I have to tell you, if we have the funds, there is no shortage of talent pool. The number of people that we see applying to med school, and I often look at those applications and I say to myself, I'm glad I trained when we did, Dr. Henderson, because if I'd applied now, I'd get nowhere. Because the young people in this audience, you're smart. Evolution works. You're better than us. No matter what anyone tells you, you're a lot smarter than us. I have proof when I look at these applications. But the problem is there's a pipeline reality which you alluded to. If you want to train a physician, the shortest time is 11 years. You want to train a surgeon, it's 13 years. Neurosurgeon, 15 years. Cancer surgeon like me, 17 years. So if you want to have one of your loved ones come to me to take out their cancer in the liver or pancreas, and you want me to be perfect or better than perfect, it's going to take 17 years. Now, some might say that, do they really need to train that long? Can we not train them for a shorter period? It's not the question of intelligence. It's a question of industry that you put in to acquire that skill set. You have a loved one that has a brain tumor, you better be sure that neurosurgeon was trained well. You don't want a fast food version of a neurosurgeon. Let's train them in 4 years and whip them out. No. If it takes 7 years to do that specialized training in neurosurgery, there's a reason why it takes that long. So what I always say is even if you give us the funds today, it will take quite some time to train the physician workforce. So conclusion, for the sake of the health and security of our nation, let us ensure ongoing stability and an increase in GME funding. This was 3 days ago. I think it was the second largest shutout in Husker history. This was beyond emphatic win, so I hope I've been able to convince you as emphatically of the importance of GME funding. Thank you.
Thank you, Dr. Ari. Thank you, Dr. Henderson. I didn't know we were allowed to put football slides up. Because the Bengals did really well this weekend. So, well, not really, but they won. So that's all that matters. Listen, this is the most important part of the briefing. Well, I shouldn't say that. That was the most important part of the briefing. But everybody wants to know, what's the ask? What do you want us to do? Please co-sponsor, get your boss to co-sponsor the Resident Physician Shortage Reduction Act. Bipartisan legislation, both the House and Senate. You see the leads on the bill. Great partners, great friends, great champions of academic medicine. Kathleen from Senator Bozeman's office is here. If you want to tell her today you want to get on the bill, she's up front to let her know. These positions, 14,000 over 7 years, gradually phased in. These aren't going to solve the problem, solve the shortage, but it will get us towards there. And then the last thing I wanted to share, resources. There are GME fact sheets that you can share, and information about your state, teaching hospitals, residents, students, all those sorts of things. But then also all that graduate medical education information we shared at the beginning available as well. There are two other resources I would just point you to that aren't on this slide. The first thing is find your academic medical center. You probably already know who they are. I'm sure you know who they are. I'm sure you're already talking to their GR folks. But go visit on a recess. Get to know them. They are a perfect source of information. The other piece I would just point out is, Danielle already mentioned her, but Ali Perleone, if you want to talk to us, have questions, please reach out to Ali. She can help. She can come answer questions, anything you need. And then the other person I would just mention is our colleague, Brad Cunningham, who's from our policy shop. Brad's over here. Brad's the one who tells Ali and I, hey, if you move this comma, this happens. If you don't cross the T or you don't dot the I, these are the problems we could run into. So those are the resources we would direct you to. So, Danielle, you can lead us through questions.
I'm going to be respectful of your time and of this meeting room, and just thank all of our panelists for this insightful discussion and for all of you for taking time. As we've heard today, the shortage is not a distant problem. It's a here and now problem, and it will only grow unless we are able to act. We have talked about the Resident Physician Shortage Reduction Act. It's H.R. 4731 and Senate 2339. I want to thank those staff who are here representing their bosses, who are leaders and co-sponsors of that legislation. Thing I want to leave you with, it's bipartisan. We enjoyed tremendous support in the 118th Congress. We had, in the House side, we had 193 co-sponsors, okay? And a strong showing, I don't have the number in front of me, in the Senate. Come and talk to us, we'll find it. But we need you. And together we can strengthen this physician workforce, expand the access to care, and make sure our healthcare system is prepared to meet the needs of every single community. Your slides were very poignant in the years ahead. Thank you all for being here, and we look forward to continuing this conversation with you. Bye-bye.